Good morning. My name's Diane. I'm going to start off first. And as Kelly so graciously stated, I have retired and I'm back. But I'm back with a passion, and how lovely to be able to promote this further using what tools that I have been able to develop with my other colleagues as your profession and career goes on. I want to also mention that this particular presentation is not meant to be a clinical one, and it isn't. We have done that where we actually spend a lot of time and looked at the effectiveness of the Staying Independent checklist, which is a checklist that seniors can do and bring to their physicians and their practitioners, which is very helpful for reviewing falls. So although we're not looking at the clinical application of how to prevent falls, we're looking at what the steering committee has completed on our behalf within the region, and with thanks to the regional geriatric program and of course the Champlain LHIN. It's a large steering group, and we're always working with Dr. Molnar, Frank Molnar, and with Kelly Milne, and it never represents any one area, so it goes across from community and primary care right through the healthcare continuum. And I hope as we move forward in the presentation, you'll be able to see where we're trying to meld the different aspects in looking at health promotion and health advocacy and fall prevention for seniors. So really what we are going to do today is look at the impact on services briefly within our own Champlain LHIN. And I wondered if you would be interested in looking at how we kind of move forward when we look at other LHINs as well, and why this remains important within Ontario for us to look at a fall strategy. And we're going to look at reviewing and comparing our previous fall prevention framework, which served us from 2013 to 2016, and our new framework that we just developed to move us forward actually almost till 2025, because we need to build a roadmap for what seniors might experience as they age right up to 2025. I hope we can describe two new initiatives that we're looking at, and an example of one program that is in development and sustainability, which Kathy has graciously come to share with us. So our vision in 2013-15 has served us right into 2016, and it talked about reducing falls and identifying really the impact of falls on the Champlain older adults through a coordinated, evidence-informed approach. So the early part of this steering committee was definitely looking at how do we bring this healthcare continuum together. And it was a broad mandate, both to identify how and where falls are, how we fit in the Champlain, within Champlain, but within all of the other LHINs in Ontario, and also to look at how can we work intercollaboratively and intersectorial, because traditionally it's very hard to bring a steering committee together that goes right from primary care, often working with very well older adults, to, let's say, tertiary care, from community care right through to any hospital care. One of the things that was identified was the impact of falls, and it's like being on a balance beam or a teeter-totter if you have children or grandchildren. It can often be underreported and underassessed. If it's underreported because seniors don't want to report that, or they're not invited to report that, then it's hard for us to actually capture accurate data. It is an extremely healthcare outcome that identifies a health trajectory. So multiple falls can reduce that balance beam, that trajectory, right from the fulcrum into the decreasing health wellness. So your health trajectory can also be balanced on falls and fall prevention. It affects all domains of healthcare, from, as we mentioned, community to hospitals. It affects every area of healthcare. You can present to the ER with congestive heart failure, and you can present 3 times. Hopefully somebody will have asked whether you had a fall, and we have new systems, as you know, in place to begin to have that conversation. It also affects the financial consumers, healthcare dollars, and resources. It's really a $2 billion care package that we're putting money into, and that's in the direct costs. And it's more than that when you look at all the other costs that are involved. So I just thought we should be aware of the impact, that this is not a small one. Fall-related ED visits for seniors. This means the person actually presents to the ED with falls. They may have other healthcare sequelae, but they came with one of their identified reasons as a fall. And you can see by the graph that we actually have started to make a difference. And if you look at the purple bar on the side, that's where the Champlain LHIN is fitting in with the other 14 LHINs. So we're about middle of the pack. If you look at a comparison on provincial ranking, the rate of falls in the ED in 2015, so April to June 2015, we were at 10, so down our ranking, down from 12th ranking in 2014. In the rate of falls related to hospitalizations, though, from the ED, we're still very low in the pack. So that means that although we may be affecting the visits, we are admitting a large number of those clients that are that present with falls. So it's these two numbers also that give us a way of framing the work. 10 and 14 in the Champlain within the Ontario provincial LHINs. It doesn't mean it's the worst, but it means that we have areas that we can improve on. We also look at repeat visits. So are there ways to do ED aversions? And this is a little too small for even me. The green or aqua is 2013-14, and the orange is 2014-15, and Champlain is the first one over here. So we're still high as a percentage of the total falls. So repeat visits, we're still getting people back to the ER, even though they had a previous presentation. And we need to ask ourselves, what could we do to help connect them with the prevention strategies that are in their community and do it better? What can we do in identifying resources that we would offer to those that do come back? If they have come back, we would prefer it not to be because of the fall, and so we should be using that as an indicator for us to look at promoting future endeavors. We can look at hospitalization rate. So let's say, remember we looked and we were middle of the pack. But we are, as I mentioned, quite low in admitting patients. So once again, not only do we have that 30-day readmit, that's a bit higher than perhaps we would like, because we have very good resources being built. And perhaps we need to work hard on making sure the strategies that transition both from ER and from admitted patients actually translate into seniors being able to do that when they are discharged. Then if you are in the ED and you have been there, are there ways and resources and endeavors for us to look at new ways to avert the ED admission? Because we have a fairly high admission rate. I'm not going to speak to the converted here. This slide speaks from 2015 to 2025 and shows again that the increase in population of seniors in Champlain will continue to increase. And when we talk from 2016 to 2019, in presenting our three-year plan, we're well aware that, as I mentioned in the objectives, it's really our role to begin to plan right through to 2025. So moving forward from this Champlain fall prevention strategy, what can we say this means? In the first 3 years that the Champlain Fall Strategy had a chance to work, they built a steering committee, as I mentioned. They put intersectorial, they put all different healthcare disciplines together. And they were able to begin to offer a fall prevention algorithm for assessing falls, which is for healthcare and professionals. They've put together the Staying Independent checklist, which is a validated senior self-reflection checklist. And that is beginning to translate within the community. So what we're looking at now is what can we do to move forward? Because the number of falls will continue to increase related to that senior population. It only makes sense if we have more seniors that the chance for more falls will increase. The rate can be decreased if we do a good job related to the dilution of the increasing population. We are making progress, and I firmly believe that fall prevention strategies can work if we can just work together and target some of the areas that we can learn to make some effective results as outcomes. Healthcare practitioners need tools to combine fall assessment with primary and community visits. There's a question, can we look at deprescribing? I'm sure you may have read in the paper a week ago about deprescribing and the research project at Elizabeth Briere, and this had already been on our roadmap for looking at and reviewing medications and those that relate to falls. And we can look at more education. So I'm here to bring you a little information about a new continuing medical education module. We have professional modules, champion training, and EMS. So where we were and moving forward. Our past was initiating the strategy, as I mentioned. We had a very committed committee. And I want to thank everyone on the committee and those that work with us, because really much of this and most of it is in-kind dollars. This is our original Champlain Falls prevention strategy for seniors, and we had 6 pillars that looked at public awareness, detection and diagnosis, best practices, and you can read that in your handouts. And what we were very focused on to begin with was also ensuring that we did not start endeavors without making sure it was based on best practices. We work with well seniors to seniors at moderate to high risk, and we work across the healthcare sectors. We have aligned our strategies and collaborated with our partners. We've continued an emphasis to coordinate. We've continued to work on expanding the role of community providers. So there are many, for example, fitness trainers that are now very aware of fall prevention and also working with fitness in seniors. How much better can that be? And we have available, as I mentioned, the Staying Independent checklist, the algorithm, and I would encourage you to go to our website at www.stopfalls.ca. We also have available a falls prevention education module for personal support workers. And we are hoping to get this online by May of this year. It has been given across the region and was developed in Renfrew, and we have and in the counties, and we have a great deal of gratitude for those that helped to develop it. We're working on an electronic medical record. I've called it a template, and the reason for that is because there are different platforms that deliver electronic medical records to different institutions, and they're not all the same. So you develop one electronic record, but it doesn't fit across all the sectors, and this causes a bit of a kerfuffle. This has been also led by Christine Gagné-Roger from the Champlain LHIN, who is taking this to a provincial platform for a conversation on how could we get this going further. And also we're in conversation with the Champlain Southwest LHIN, who have actually got one up and going, and it's doing extremely well. We also have a LHIN-wide exercise navigation tool that has just been built, and it is helping those that need to refer to exercise classes in the community. Another wonderful endeavor. We've increased our education in 2014-15. We had 9 agencies who received fall prevention training. And in 2015-16, we had 30 agencies. So that's a great increase, and once again, dedicated in-kind dollars often being given for this. We have an increase in seniors accessing classes, and we, as I mentioned, CCAC is actually working in training in fall prevention and HeartWise programs. So right now, for us, I don't know why I've got 2015-15, it's 2015-16. We're also there. CCAC is also working in population-specific exercises with Parkinson's, diabetes, stroke network, and Alzheimer's, ensuring that exercise groups and classes have an opportunity to be aware of the impact on seniors. We had a retreat this year, and we completed that half-day retreat. And during that retreat, we revised our mission and grouped our priorities. So our revised vision for the carrying us for the next 3 years, from 2016 to 19, is a little simpler. It's an accessible, sustainable, and integrated approach across the continuum of fall prevention for older adults. And we're looking at access, awareness, integration, and sustainability. And part of the reason that we chose these pillars is in order to be in full alignment with the Champlain LHIN 3-year strategy. So we have exactly client-centered care in the middle. We feel sustainability envelops all the domains of access, awareness, advocacy, and integration. But we felt strongly that we needed to leave, that we deliver this care and build this care for both well seniors right through to those at severe risk. So I would like to take the opportunity to ask Kathy McCumber to come and just share her program that's developed at the Ottawa Hospital and what it looks like in order to work with sustainability and to work with how you can use parts of what we've developed in order to segue people back to the community.
So good morning. My name is Kathy. I'm a geriatric nurse specialist here at the Ottawa Hospital, and together with Lisa Freeman, I co-chair the Ottawa Hospital Fall Risk Reduction Work Group. So what I'm going to talk about is really just a brief overview of our inpatient and our ambulatory care fall risk reduction program. And I'll go through some new initiatives that we have, and I can see Diane looking at the clock. It'll be about 10 to 15 minutes. And as we review this, I'll share some of the new exciting initiatives that are going on within our program, and also how we are looking at the program to also align ourselves with the Champlain LHIN's Fall Risk Reduction Work Group as well. And so the whole idea of having something that's patient-centered, having something that is very accessible to patients, increasing the awareness, and how we're going to be integrating our program with what's going on in the Champlain LHIN. So just a little quick sort of stats. If we look at patients who are over 65 and who are admitted into acute care for falls, we find on average that they spend about 22 days, around 3 weeks in hospital. Patients over 65 who are admitted to hospital for any other reason spend on average around 12. So if you think of that, that's 10 extra days that patients who are admitted for falls will spend in acute care hospitals. So when we think of the fiscal dollars and the healthcare dollars that are associated with falls, it really speaks to how fall prevention, both in the community and also here in hospital, are really a huge priority for the seniors as well as for the hospitals themselves. Here in the Ottawa hospitals, falls remain one of the most common adverse event that is recorded in our patient safety learning system, and that's the incident reporting system here at the Ottawa Hospital. So again, we have still a high prevalence of falls. So our two programs are our inpatient and our ambulatory care program. They're both evidence-informed best practice programs, and we used several models in developing them. And basically, best practice states that if you're going to have a fall risk reduction program, that you need an assessment and a screen for fall risk. You need to have education, both for staff as well as patients on fall risk and their on fall risk interventions. And interventions need to be universal, so accessible for everyone, and there also has to be an individualized component. So both of our two programs embrace these and have these within their, within the frameworks of the programs themselves. And what we're looking at moving forward is how we can align this and ensure that our programs are in alignment with what's happening in the Champlain, that again, that they're patient-centered and that we have access to the right interventions at the right time by the right professional at the moment in which the client needs it, that there is a client awareness, and that we are integrated with the Champlain initiative. So what I'm going to do is I'm going to talk first a little bit about our inpatient fall risk program, and then I'll talk about the ambulatory care program. So for our inpatient fall risk reduction program, one way in that the patients have immediate access to the fall risk interventions is we do a screening. And so our screening is done within the shift of admission. So within the first 12 hours that a patient is admitted to the unit, they're immediately screened for fall risk. And that way, if a patient is screening as a fall risk, we then start and initiate an individualized fall risk care plan. So again, getting the services to the patients in a timely manner. Now for patients who are not screened as fall risk, they still have access to our fall risk reduction initiatives because we have that universal, that blanket intervention program that goes on throughout the entire hospital. And so these universal interventions, as I said, is for every patient. And again, the patients are ensured that they're having access to these interventions because during rounding, so our nurses round on patients every hour. So every hour, a nurse will come into the patient's room and they do something that's called sort of a 6 for safety. And these are our high-hitting, what we know are very evidence and targeted universal interventions to help reduce fall risks for our patients. So every hour the nurse will come by and they will do, and it's very simple. The call bell is by the patient. The bed is in the lowest position. The patient has their possessions within reach. The patient has, their footwear by them. The room is decluttered. The mobility aids are near the patient. So this way the client has access to our universal strategies. So this is where our inpatient fall risk screening occurs. When a patient is admitted, we are screening patients for fall risk, and the fall risk screening is part of our admission history. Now this is relatively new. We used to have a separate document, and it would be in the chart, and then the nurses would have to complete a large amount of paperwork, including a fall risk assessment. Now that we have the fall risk assessment embedded inside the nursing history, it's sort of one less place that the nurses have to look, and also it really highlights the nurse's awareness. It also helps do that sort of integration thing, because fall risk is now screened as a complete part of the nursing admission history. And so what we're looking at, has the patient fallen within the last 3 months? Is there impairment in mobility, impaired mental status? And what is the nurse's clinical judgment? We always leave room for that as well, saying, do you feel this patient is at risk for falls? If they screen positive, we implement this. Now this is brand new, so anyone working at the Ottawa Hospital may look at this and go, I have no idea what that is. We're actually piloting a patient-centered fall risk care plan. So this care plan is actually going to take place of what's currently in use. So currently we have this purple fall risk assessment profile. And historically, this had been our screening tool, it had been the intervention tool, it had been our communication tool, so it was sort of that one-stop shop for everything. But because we now have the assessment as part of our admission history, it's really allowed us to revamp the inpatient fall program. So what we have now is this tool. This tool does a really nice job in ensuring we have an integrated approach, ensuring that the staff as well as the patient are aware of fall risk, and also ensuring that they have access to all the appropriate interventions. So this is filled out by the nursing staff or any one of the interprofessional team members, and it is only on the charts of patients who are a fall risk. So that really helps in terms of highlighting the awareness that this patient is a fall risk. So this is being trialed, like I said, in a couple of units. Hopefully it'll start rolling out come the summer and fall if all the fall risk stars align, but that's our direction forward. And increasing awareness of fall risk for our patients and also for our staff members. So one way that we increase awareness of the fall risk for our staff is that we have a fall icon on the electronic clinical whiteboard, which is by the nursing station. Another is again through putting Cardex on in red that we say patient is a fall risk. And patients and clients and family members themselves were enhancing that kind of awareness, because in bedside shift reporting, so every time a nurse comes off shift, another one comes on, they go together to the patient's bedside, and one of the things they're encouraged to review with the patient is their fall risk, and that's how we're informing patients that you are a fall risk. And also the individualized patient care plan. The patients also have in their room a patient care board, and on that care board they will write, or the nurse will write, that the patient is a fall risk. So again, ensuring that patients are aware of their risk for falls. In addition, we also have this integration piece. How can we bring the good work that's being done out in the Champlain community into our hospital? Simple, we just take all your tools and bring them in. So we have two education handouts. One is the how to reduce your fall risk in hospital, and the other is how to reduce your fall risk at home. And truthfully, the how to reduce your fall risk at home is actually just the you can prevent falls. So this is the strategies that clients can use in the community, and it's the one that was developed through the Champlain LHIN work group on fall prevention strategies. So we've simply taken that, we retitled it just to put it in line with, how to reduce fall risk in hospital and home, and we basically bridged. So these are the strategies that are currently in use out in the community. So for our ambulatory care program, when developing the program for ambulatory care, it was a little more challenging because of the heterogeneous nature of ambulatory care. So you can have a lot of programs that have quite robust interprofessionals and nursing staff, such as a hemodialysis program or the emergency department program. And then you can have other programs where literally it could be just a physician and his administrative assistant, for example, like an eye clinic. So in the development of an ambulatory care program, it really is a very patient-centered and patient-driven program. And this is one really that Diane Rossi was a really big push in the development of this program. So on first accessing and coming to our ambulatory care settings, again, patient will have access and awareness of fall risk, and first by the implementation again of universal fall risk interventions. So in the ambulatory care, every patient will have these universal things in place to help reduce their fall risk. And it's things like reducing clutter, ensuring that patients can have their family and loved ones with them as long as possible. It's having the equipment, making sure it's all in functioning order. All of these sort of things are just standard processes in all our ambulatory care programs. But then the client's invited to do their own fall risk assessment. And this is done by these great looking posters. So these posters are in all of the ambulatory care centers and in the ambulatory care clinics. They're very bright. One is in English and one is in French, just to enhance the readability. And in this way, it's really increasing sort of patient awareness and access to their fall risk and fall risk interventions. So the way the posters work is the patient is first, right at the beginning, are you at risk for falls? On the right side, that first column, they're then invited to complete a fall risk staying independent checklist, and that's the one that Diane said was the evidence-informed one that was developed through the Champlain Fall Risk Prevention Work Group. In the middle is the individual fall risk interventions that patients are invited to use while they're here in the hospital. And then on the far left are the universal interventions that we are going to be implementing to, again, help minimize fall risk when they're in the hospital. So this poster, right underneath, have two handouts. One is the Staying Independent checklist, and this is the one, again, that we're bridging, and this is what's currently being used in the community. So a patient, is invited to complete this. If they are identified as having a fall risk, they take this handout back to their family physician or their GP, and because this is what's used in the community, the family physician is very familiar with that. And the other way that we're bridging what's doing in the Champlain area is our How to Reduce Fall Risk at Home is, as I said, the You Can Prevent Fall information sheet that also is used in the Champlain LHIN. So in that way, we're already bringing what's out in the community into our acute hospital, into the ambulatory care setting. So just a little peek behind the veil of two other little initiatives that we are doing in our fall risk work group. We're re-looking at our patient safety learning system, and by re-looking at this and retweaking it, we're hoping to sort of get more targeted interventions. So we're trying to look at a way that we can capture information that's more robust. And another thing that we're going to be looking at is actually how our ambulatory care fall risk reduction program is rolling out. One of the challenges we have is the placement of posters. Are the handouts in a way and in a location that's easily accessible for patients, and that type of thing. So that's an audit that will be coming hopefully again soon. And that's our ambulatory and inpatient fall risk reduction program.
So moving on, as mentioned in the objectives, I was inviting you to have an idea of how we have started to move between the community, through primary care, from doctors' offices into the ED or other ambulatory care clinics. And the Ottawa Hospital has graciously shared this program for adaptation in many other facilities with permission. So our revised priorities in tying this up is going to be looking at the algorithm implementation, because although we have looked very hard at trying to get the Staying Independent checklist out, and primary care has done wonderful. Public health has actually sent out large briefs and also the staying independent checklist has gone out community-wide, but we all know that doesn't mean that it's actually used everywhere. So also we need to get to more family practice units and encourage the use of the algorithm for the assessing of seniors with a fall or without, one who's remaining well at this point. We want to standardize the training modules and best practices. It would be best across our LHIN if we weren't all teaching different things, and that's why we are very excited to have the personal support worker, which has actually had some adaptations for EMS. And in many counties, the EMS are very heavily involved in fall-related home visits, and it's wonderful that they get an adaptation of this. Hopefully on our agenda for the future, as I mentioned, will be to complete a module for nursing and professional practice, even if we have the ability to adapt off one that might already be developed, that would be great. And ensure that across the Champlain LHIN, when you learn about falls, you learn the same information. The actual implementation of interventions may change to fit a region, of course, that would make sense, but the basic information and the assessing and the algorithms would hopefully be all the same, and we hope to make this happen. And one of our hopes is Dr. Molnar's continuing medical education development, because in this way we could invite practitioners, primary care, or whoever to use this continuing medical education module as one of their ways of maintaining their up-to-date licensing and education. We have to work on navigation. We have to work between how we move people between all those sectors that we talked about. We have to work on our communication tools, and this includes our branding. Wouldn't it be nice if everyone across Champlain had the same way of speaking about fall prevention? For example, we don't need to put in Barry's Bay or Mulford Hospital or Renfrew Hospital, but rather that we have an accepted brand right across the Champlain LHIN. We thought that we would move into retirement homes. There's always already been a telephone review of how retirement homes are doing, and they are a hotspot. And they are a collection of seniors for us, and they're high-risk seniors, many of them, as we know. So we thought that we could use that as one of our priorities, and mentioned we have to move to 2025. So we're going to look to improve the communication and assessment form. For example, a patient seen in the eMERGE, do we send a letter back home clearly identifying what you want the physician, that primary care or community physician, to follow up on? Do we? Are we clear that it's this medication, or can you look at these? So we're working to develop that. We're going to work on ensuring that the navigation for exercise and all the exercise classes are at the right program at the right time, and we've made good steps in that. And we're going to look at the communication tool. So let's get that CME completed. I'm the worst person for this. I am trying to help Dr. Molnar, but I'm not a great person. He's like technology, you know, I was better in geriatrics. You don't want me in ICU. Investing in interprofessional training, that's what we're going to look at as well, and use our in-kind dollars, and also look for any other ways of adopting and pursuing dollars that could help. Because once you look at the falls in seniors, you will develop an understanding of all the other trajectory that may help with their either health promotion wellness or that may be dragging them down in the trajectory of some loss in seniors' health. We're going to hope to have the EMR development and our public health awareness. As I mentioned, we hope to invite the retirement homes, and although you can't see this clearly, I just thought it was very interesting how the Champlain LHIN, through using some of their collected stats, because we must send in our stats to the Champlain LHIN on falls, they were able to use postal codes in order to help us identify hotspots where falls were being reported. Isn't that interesting? It helps us. And one of the most interesting things that we learned was several of the concentrated areas are all where there are large retirement homes. So it's a good learning point for us, and it's just one example of moving between developing and Champlain-wide outcomes. So we're going to look at a pathway for emergency departments and maybe invite multiple emerges to look at that. We're already starting at the Ottawa Hospital. How can we build the ambulatory care program in EDs, but also that real intervention part while you're a patient in the ED? We're going to target some of our knowledge and interventions on the 3 Ps. Pain, pills, and postural hypotension and mobility. And this is because we can get the biggest bang for our buck in looking at interventions targeting that. It does not mean that those are the only interventions, but they certainly help us to focus interventions that perhaps all are often all together within one patient. I want to say also that although we're only saying pain, polypharmacy, pills, whatever you want to call it, and postural hypertension, these are based on best practices. And if we look at wherever you are, whether you're in the doctor's office or whether you're in ED or whether you're up in any hospital, it would be best in a senior if we were able to report for postural hypertension. I'm not sure we always do that. I'm not sure we ask people to sit and stand or to lie and stand and do a proper postural hypertension. When we look at mobility, we need it standardized across. If somebody has used a sliding board all their life and is using it now, I don't call that a major change in mobility. We're looking at what is the major change in mobility, gait, balance, because we know that's one of the largest indicators of fall risk. So we have a lot to do. As I mentioned, this particular presentation is an overview. We've given you more, I hope, than 2 endeavors. We've given you population-specific exercise classes. We've given you fitness training where we're looking at standardized training. We're looking at standardized modules. We have a great deal of thanks for all the different regions that have participated and brought their expertise in different ways. Barry's Bay and many, even Akwesasne Reserve was looking for assistance and are now beginning to build programs. So we have nothing but thanks for the spread of this, but we have a lot more way to go.